Hi, I'm Dr. Janet Pope. I'm live at Room Now, and I'm reporting here at EULAR, hashtag EULAR 2022. I want you to follow us at Room Now, and I'm at Janet Burdope. So, this is a report on psoriatic arthritis, a heart throb or stopper. So, I wanted to be provocative in the title because, as you guessed it, there are some studies here looking at psoriatic arthritis and cardiovascular risk. So, we do know that there are several cohorts that show psoriatic arthritis has increased MACE, so major atherosclerotic coronary events, strokes as well, less often. And there's also some studies that say how much is a traditional risk factor, and is there a gradient between psoriasis and psoriatic arthritis? Psoriasis maybe having less, and psoriatic arthritis having more, possibly endothelial dysfunction and cardiovascular events. So the first study that I'm going to talk about is a long-standing registry from Toronto, Canada. And what they did was they looked at the cardiovascular risk and disease activity, functional impairment as measured by the Health Assessment Questionnaire Disability Index, and damage. And they said, is all that psoriatic arthritis stuff driving events, or is it the comorbidities, or is it both? And the bottom line is the event rate was low. They looked over about 30 to 40 years. So our treatment of both cardiovascular identification and treatment has changed, and psoriatic arthritis treatment has changed. However, what they found in this retrospective study is that, first of all, it's reassuring because the event rates weren't very high, and there are limitations. They often were lacking cholesterol levels and C-reactive protein. But what they did find was that there were cardiovascular events, and most of the data were driven, as you guessed it, by traditional risk factors: hypertension, high BMI, hyperlipidemia, where they knew, past cardiovascular events, type 2 diabetes, metabolic syndrome, and hypertension. And they really couldn't find a drug driving it other than two main areas: chronic glucocorticoids, which has been shown in every database and here as well. So it has good face validity. They also showed that NSAIDs will increase cardiovascular events a little bit. So along that line, there was another study by Lars, Erik, Christensen, and what he did was looked at the tofacitinib randomized controlled trials and long-term extension in psoriasis and psoriatic arthritis, and was looking at incident rates for MACE. So the first thing is tofacitinib is not driving the data when you do a logistic regression. What's driving the data in general is not active versus placebo. It is the usual traditional cardiovascular risks. The second thing that he found, which I think is interesting because he looked at psoriasis trials, psoriatic arthritis trials as well, was that there seemed to be a gradient of response. Psoriasis had a certain level of cardiovascular events, but it was indeed higher in psoriatic arthritis, even though the BMI and obviously the body surface area of psoriasis was on average far higher in psoriasis trials than in psoriatic arthritis trials. What does this mean? Some of that is probably the risks associated with inflammatory arthritis, more hypertension, not a higher BMI, but also higher CRP. So although traditional risk factors drove the data and the event rates were very low, it didn't look like tofacitinib drove the data, but there were low events, but still higher in PsA than PSO. What will this do when I go to the clinic next week? What it will do is I will be aware to really identify and treat, or ask the family physician to treat all the traditional cardiovascular risks, smoking cessation, things like that. And if we don't identify it and ask someone to help us treat and reduce risk, then we're not doing our patients a service. So please follow us at Room Now, and I hope you enjoy listening to the meeting. Thank you.